Welcome, friends. Thank you very much for watching this video and joining my channel. As you know, it's directed toward medical students as a clinical tutorial. Today, I have chosen a topic that is exciting and will be beneficial to have an idea about what it is and how we manage that. And it is the gastrointestinal stromal tumors. Now, these tumors in the past, they used to be called leiomyosarcoma or the gastrointestinal tract sarcoma. And the reason behind that, because of their histologic pattern, and the histologic pattern is a spindle cell lesion that have got some symmetrical sheets of cells and connective tissue in between. It is the most common mesenchymal tumor in the gastrointestinal tract. You hardly see any other tumor of mesenchymal origin in the gastrointestinal tract, and it can affect the gastrointestinal tract from the esophagus down to the rectum. Majority of them do happen in the stomach, so about 70% of these tumors do arise from the stomach, and they affect people. Usually, the median age is about 60. They do affect other sites in the gastrointestinal tract, and that's the duodenum, where the treatment can be a bit more complex. Also, they occur in the small intestine, the colon, and also the rectum. As I said, it's previously called leiomyosarcoma, and until recently, and I will explain that in the next slide why. The lesion usually arises from the wall of the stomach, but they could primarily arise from the omentum or the peritoneal cavity. That does happen in exceptional situations, such as the Carney triad. I'll explain that to you if I have a minute later on. Now, we do need to understand the pathology of these tumors. As I said, they were considered to be a leiomyosarcoma, which means that it is arising from the tumor, malignant tumor, arising from the muscle wall of the stomach, or sclerus propria. They still do, that's their site of origin, but they are not malignant cells of the muscles themselves. They do arise from an autonomic nerve-related cells that are called the pacemaker of the gastrointestinal tract. It's also called the interstitial cells of Cajal, after the person who discovered and described them, and evidently he won the Nobel Prize early in the 20th century for his contribution. These tumors in general are regarded as malignant until we prove otherwise, because some of them do have that feature of growing for a while, and then they can stop and remain stable due to growth arrest for whatever the molecular reason behind that is poorly understood. It has been found that there is a specific mutation in these cancers that's actually the oncogenic factor that lead to development of these tumors, and it's called CD117. Now, what exactly it is? It is a transmembrane tyrosine kinase receptor. So it's receptor for growth factors and other factors that affect the growth and the division of the cells, and on any cell in the human body that's given, there is a myriad of these transmembrane tyrosine kinase receptor. So they get signals from outside the cell, and then they convey the signal inside the cell by the secondary messengers, and the secondary messenger will take that to the nucleus to tell us whether to start the process of mitosis or not. 70% of them are positive to another tyrosine kinase receptor, which is CD34, and this is different from the other one because it is hematopoietic hematopoietic progenitor cell antigen. So it's related to the hematopoietic system and its effect on the tumor and the process of neoplasia in this situation is poorly understood. There is a subset of these tumors that do not have these two mutations, the CD37 and CD117, but they have a mutation of a different type of tyrosine kinase receptor, and that's the platelet-derived growth factor alpha. Platelets produce a lot of factors, and some of them are growth factors, and one of them is the growth factor alpha that seem to be mutated in some of these tumors, and it contributes to the process of carcinogenesis by this mutation. Now, how do these patients present to us? In general, you're not going to take history and examine the patient and tell whether they have a gastrointestinal stromal tumor in their stomach or their intestine, because generally the symptoms that patients present with are non-specific. And this can be in the form of dyspepsia, nausea, early satiety. If they are in the antrum of the stomach, they could lead to gastric outlet obstruction. They could bleed if they erode into the mucosa and present as upper or lower GI bleed according to their site. And some of them are incidental. And the incidental ones are the ones that we find in patients when we scan them for a certain purpose or do a gastroscopy for a certain purpose, and then we find they have got a lesion in the stomach that has not caused them any symptoms so far. Now, how do we investigate these lesions? Obviously, CT scan these days is quite widely available, so everyone will get a CT scan, and that should include the chest, the abdomen, and the pelvis in order to stage the tumor, in addition to identifying the source of the origin of the tumor. If we do a gastroscopy, if the tumor is right on the periphery and it's small, you may not be able to see any abnormality on gastroscopy. But often they can be large and they erode into the mucosa, and then you could see them as a lesion in the wall that bulges inside, which is very different from cancer of the stomach. Once you see the appearance, you will not forget how it looks. Laparoscopy does play mainly a therapeutic role in these lesions, but on certain occasions we've been doing some gallbladder or an appendix for a patient laparoscopically, and during the diagnostic laparoscopy stage of that, we see a lesion on the stomach, and the lesion is easily identifiable on the outer surface, usually of the stomach, in the form of a lobulated, which is called a bossulated solid lesion. If there is any confusion about the diagnosis, an EUS can be useful in those situations to describe the site of the tumor and its relationship to the mucosa and submucosa, and also fine needle aspiration and biopsy could be taken via the EUS, but this is not a routine investigation in these cases. We use it selectively. Now, we need to know something about the staging of these tumors. Until recently, there was no specific staging system. More recently, in the last few years, now we have a specific a staging system for them according to the TNM, tumor node metastases, fundamental system that get applied to all cancers. And the most important part of it, obviously, is the T staging, because the N staging is either 0 or 1 if there is no, or if there is or there is no lymph node metastases, M1 if they have got metastases, and M0 if there are no metastases. But the T4 plays a crucial role in the staging according to the size. So it's easy to remember as well. T1 is less than 2. If they are between 2, less than 5, then they are T2 tumor. If they are between 5 and 10, they are T3. Tumors more than 10 centimeters are T4 lesions. And the prognosis will be proportional to the stage of the tumor. The detrimental factors really in the prognosis are the T staging or the size of the tumor, and the cutoff is 5 centimeter. If the lesion is bigger than 5 centimeter, it is considered as malignant, particularly if they have high mitotic rate. Now, in terms of metastases, lymph node metastases for these tumors, because they are considered as sarcoma, they rarely metastasize to the lymph nodes. Only about 10% of them do. And in terms of distant metastases, that can be the peritoneal cavity, could be the liver, could be the lungs, it could be the bones. So we've got a nice staging system for these tumors that will tell us how advanced the lesion is. Now, it's important to know the clinical behavior. How do they behave? Because according to their staging system, and what we know from the literature and the experience is that some of them are benign and they stay benign and they do not progress, they do not metastasize for unknown reason. How do we judge their clinical behavior? Now, some of them, as I said, are benign, but we want to see what are the features that would predict malignancy or malignant behavior and metastatic behavior of the tumor. The mitotic figure plays a crucial role here. So if they have 5 or less mitosis per 50 high power field, they behave in a benign fashion. So the pathologist will count the number of mitoses under 50 high power field, and that will give us an idea about the behavior of the tumor. If they have got more than 5 to, sorry, this is supposed to be 5. If they have got more than 5, up to 50, they are malignant, and if they have got more than 50 mitoses per high power field, then they will be considered as highly malignant, quickly metastasizing tumor. Other feature that will help us is the size, and the cutoff is 5 centimeter. Also, if under the microscope the pathologist see necrosis, the degree of atypia in the cells, the hyperchromatic irregular nuclei that they see under the microscope, and also there is a specific stain for the c-KIT mutation, and if they have got the c-KIT mutation, they tend to behave more in a malignant fashion. That's the CD117 and the CD34. If we take all tumors of this type, the gastrointestinal tumors of the stomach, it's been considered that almost 80% of them are benign. I think the statistics here are a little bit skewed because it would take into consideration very small lesions that have been discovered in the stomach when the stomach has been removed for other reasons, such as obesity surgery or cancer surgery. The management of these tumors rely mainly on surgery. So, resection is with a negative margin is the cornerstone of cure. This often can be achieved laparoscopically, where the lesion has been removed here. Where this is the left lobe of the liver and falciform ligament and the diaphragm there. That's the stomach. So the surgeon here is grabbing the stomach and lifting it up, and then they are stapling the stomach, just like you would staple the stomach for obesity surgery, until you detach the specimen from the stomach, and that gets retrieved and sent for pathology. So there is no lymph node dissection in particular that will need to be done in this situation. in particular in these small tumors. So the operations basically look like a mini sleeve. Every now and then we might need to do some form of a partial gastrectomy, like enterectomy or subtotal gastrectomy in lesions that could be big or sitting on the posterior wall of the stomach close to the left gastric artery. Then we have to do a partial gastrectomy or a subtotal. With that, there will be inevitably some lymph nodes removed, but we don't do extended lymph nodes. Very rarely you will need to do a total gastrectomy, and the only time I had to do that is in a Carney syndrome. Carney syndrome is a triad or Carney triad, wherein a patient inherits a certain gene that predisposes them to develop three pathologies. Just tumor, and the just can be in the stomach, in the omentum, in the peritoneal cavity, and that in that case, that's what I had. And also they have got a benign fibroma in the lung, and in that patient, their lung fibroma was discovered and removed a few years prior to her presentation with dyspepsia and indigestion. And also she's got an adrenal lesion that was deemed to be benign, and nothing needed to be done for that because it remained stable. The reason total gastrectomy was chosen is the fact that they are aggressive and they have got very high risk of recurrence. Patient did well, I'm glad to report, and now she is 4 years down the track with no evidence of recurrence. She went on adjuvant treatment, which will we highlight in the next one or two slides. In general, for surgically treated patients or patients who needed to have surgical resection of the just tumors, wherever they are, it will be somewhere between 30 to 60%. So it is compatible with long-term survivals. I think the statistics are now even better because more recently the adjuvant treatment has been modified for a prolonged period of time. That we will shed light on in the next slide or two. Which means that you do need to reassure the patients, particularly if their lesion is small, that this type of cancer is slowly growing and it is compatible with long-term survival, good long-term survival, but some of them do behave in a highly malignant fashion where they recur and metastasize. And now we go to the adjuvant treatment. These tumors, in general, in the past, everything was tried, like the conventional chemotherapy based on doxorubicin or oxaliplatin. The response was minimal and insignificant. The same thing for radiotherapy. There is no response until the drug called Imatinib, which is a Gleevec, also called. You can see here the Imatinib tablet, 400 milligrams. It's a medicine that has been used successfully to treat chronic myeloid leukemia. And then after the discovery of the c-KIT mutation, this drug has been tried on gastrointestinal tumor with a huge success. It's opened, in fact, the door for a molecular engineering to produce monoclonal antibodies against a variety of cancers. Imatinib is one of the first few that were discovered, and now there is a large number of them, and they have been applied in a variety of cancers, successfully in melanoma and breast cancer. So it's molecularly engineered monoclonal antibody. And what they do, they go to the tyrosine kinase receptor, as we mentioned earlier, which is the source of the signal of growth and mitosis in these cancers, and they block the tyrosine kinase receptor to stop the growth factors from prompting the cell to divide. There are other applications for it. And before I go further, these medicines or the Imatinib tablet after surgery, it's given for a year, but now In certain centers, it has been extended for even to 3 years, and it seemed to have boosted the survival rate of patients with malignant gastrointestinal stromal tumor. It also can be used to downstage the lesions. If the lesion is advanced and we think it's not resectable or resectable with high risk, then it could be used for a while to downstage the tumor and then reassess after a few months. And if there is a response, then you could do a salvage surgery. Also, it's beneficial and prolongs survival in patients who develop recurrent disease, particularly those who have non-resectable disease. And by non-resectable disease, I mean if they have metastases that have gone to a variety of organs, particularly if there are multiple metastases or more than a single organ. But if it is a single lesion in the liver, which is an unusual scenario, then we can resect that. We still could resect just that has metastasized to the liver, and occasionally chest surgeons could consider removing a single lesion from the chest in selected patients. And they would go also on some imatinib. But often when they recur, these lesions are in multiple places and usually multiple lesion, which make them beyond cure, but they can benefit from palliative course of imatinib. Thank you very much for watching my video, and I hope this lesson has been useful to you. And I would thank you again for subscribing and watching my channel, and let us know if you have any queries or suggestions. I will see you in the next lesson.